we have an interesting case for you planned. We're here from St. Boniface Hospital, Winnipeg, and with me today, Dr. Bruni, Dr. Arjun Gupta, Chelsea, our team, Leonard. And we're going to start with our presentation, and I'm going to ask Dr. Minhas to go with the presentation.
Great, thanks. So I'll go through the case. It's a very interesting case of an uncrossable lesion. So I'll introduce the case history. This is a 53-year-old gentleman who has an extensive vascular history of hypertension, diabetes, smoking, dyslipidemia. His index procedure was done for outpatient class 2 angina. He started off with a coronary CTA showing extensive calcific 3-vessel disease, went on to have coronary angiography demonstrating multivessel disease. Given his age and comorbidities, including diabetes, he underwent 4-vessel CABG, as outlined there, with arterial Lima graft to the LAD and then vein grafts to the first diagonal, obtuse marginal, and PDA. Unfortunately, shortly after his bypass procedure, he had a return of angina. He had a myocardial perfusion study showing still preserved LV systolic function, but a large territory of infralateral ischemia, and was referred back for cardiac cath. Left system showed that he had graft to the obtuse marginal was occluded. He had a severe lesion proximal to that second OM. The RCA graft to the PDA was also occluded, and he had a severe calcified proximal lesion as well as a mid lesion, and then a separate lesion in the PDA. His arterial graft to the LAD, as expected, is patent, but you can see it's to quite a distal LAD target, and the vein graft to the diagonal was patent. So at the same procedure, ad hoc PCI was attempted of the RCA, but wire was able to get across, but they could not cross with the balloon. So the plan for today, given that, would be upfront orbital atherectomy with OCT guided PCI. Just a bit of background on balloon uncrossable lesion. This is from Dr. Barlakis' paper, and they attempted some of these maneuvers with trying to cross with a smaller balloon, increasing the guide and the wire support, but they were unsuccessful. They didn't try a granuloplasty at the time, and so now the patient's back for procedure with upfront atherectomy. So I'll turn it over to the team in the lab.
We have a 6-French catheter in the vein. We have a 7-French hockey stick guide, and you can see our hemodynamics are stable. Heparin's been given, and we're ready to wire the vessel.
So there's a PDA lesion that we're not planning on ablating. Our focus is going to be on the mid-RCA. You can see there the wire has gone down the PDA branch. Now I'm going to start advancing very slowly. All right, it's 1 millimeter per second. And step by step, like not continuous pushing, so that you don't push a lot of storing on the burr. So you can see there I'm hitting a point of resistance, and there it jumped forward and across the lesion. All right.
So the good part is there's very minimal no reflow there. The STs are covered, and he's done well. So we'll get our balloon tip pacing wire in.
All right, so we're going to start again. So he's got his native rhythm now. We'll see what happens when we're ablating on the way back. So we've ablated on the way in and on the way out. I'd like to do one more run in and out. It'll probably move a little bit more, a bit more faster, because I still hear a lot of auditory feedback. That there's actual ablation happening. So it's moving much more smoother now. And I'm not really getting a lot of auditory feedback that there's ablation happening. So I think we'll do one more run on the way back, ablate on the way back, and then we'll get a beamer down and do OCT. The inner lumen, the diameter, even though we've ablated, is only 1.13. Tells you that there's still room to go. The vessel itself is big. Like we can take, if we really wanted to, we can probably safely do 120 kRPM, but it's more than 3 for sure. But let's take the OCT out. Let's take a 3.0 long NC balloon, see if it cracks with the 3.0 NC, and then we'll take it from there. We know that we can cross the lesion, right? We've demonstrated that with the OCT. Yeah. So going up with the NC balloon.
That's probably what I would land my stent.
Yeah. So I'm at 16 there.
Clip there so we can see the extent of it.
So it looks like there's a bit under expansion there. We'll come back and go higher pressure. So I'm at 20.
Yeah, still a little bit of a
burst. And my balloon burst. Okay, so
no, just take it out.
Take it out, flush the system first, yeah.
Yeah.
So we've moved from an uncrossable lesion to an undilatable lesion.
Just make sure.
So it's opened up,
I say we go over it another round.
Another round. I'm going to take a 120.
I think so.
Yeah, we still need to ablate for sure. We need to modify for sure.
Yeah,
The
so we'll take
balloon.
universal out.
Yeah, take the beamer out. Let's take the crown back. So we decided that we're going to go with the 120.
Just make sure. I'm just going to explore here.
What do you want?
I'm just going to see whether we have any dissections anywhere that we can not going to propagate. No, look.
Oh, there's a lot of resistance there. So it tells me that I'm ablating more.
Yeah.
So you're ablating now in the proximal lesion, which on OCT showed some degree of a nodular segment. So this should work well.
Okay, so jump forward there a bit. Give it a pause there. So glad we put in the pacer wire because we're doing a lot of ablation and it's becoming pretty pacer dependent.
Mm-hmm.
So now you're in the segment where the balloon ruptured.
Yeah.
That's the right in the mid segment. I think it was the tightest spot. Then that's where we were having difficulty last time getting our catheters across. Perfect.
Good.
I think once you make it through the mid segment, which we're
kind of running out of burst space here, so my wire space here. So we'll keep on going.
Yeah, I think you're right at it.
Okay. I'm going to start coming back. And then we'll do more ablation on the way out.
Yeah, I think you're always out of it. That's good. Let me jump forward a little bit there.
That's advancing smoothly now. There is where I got the first run in.
Yeah.
So I'll sit there a bit, then gently advance. Get the 30-second mark there.
Yep.
I got more room with my advancer here.
Should we try the 3.0 again, or
I think so. I think we just take an NC balloon, try again.
is it worth re-OCTing it?
I think, just for sake of time and all that, we should probably do another, just to take the NC balloon, see if it cracks. And then if that doesn't work, then we'll have to think about other balloon-based modification.
You can ask if he has having any pain.
Cutting balloon might
Give him some medications. He's having.
Cutting balloon is probably a reasonable option. I think it's got a 50-50 chance to work. I just think from a cost perspective, it might be more cost efficient to go to shockwave. You can see the monitor, there are some ST changes there. Might be obstructive. We got reasonable flow on puffs there, so we haven't really caused a lot of no reflow. The lesion itself looks like it's expanding. So let's, are we getting the adenosine? So we're getting some no reflow meds. We usually give adenosine, we got a pace wire here, so it shouldn't be an issue. If we had poor flow, we might use a microcatheter to deliver it more distally. Also, give me the beamer as well, please.
There we go.
Do you have the beamer?
Do you want to balloon the PDA? Like get another wire into the PDA?
Yeah. I'll take the beamer in down there and get that going. If the wiring proves challenging because of dissections, we just do a wire exchange over the over a microcatheter. Give us the wire introducer there, please.
Yeah, I think the PDA we probably might as well wire it and balloon the PDA because that's probably where the STs are coming from.
Give us a 2.5 balloon, please, Softy. 15, 20. I'm gently advancing and torquing. Pretty smooth there.
You just
Go into cranial view, please. Sounds good. On the monitor, the STs seem to be resolving, so we're Going in the right direction. Puff there. So we did very aggressive ablation here with the 120. So if it still doesn't crack with an NC balloon, then the next step would be to take a go up there. So we're just ballooning the PDA proof flow down there.
It's 12.
And that is expanding well. So that is not an issue. So that makes life easier. Good.
Down 12.
So STs are getting better. Should we give adenosine or hold off for now?
I think it doesn't. You don't need it. I think it's
Sounds
mostly
good.
because of the
Okay.
likely.
We're not going to take the orbital down anymore, right?
You want to take out the Viper?
So we can take the Viper wire because that's not going to be our next step. Just to simplify things here, we've got a wire down the vessel already. So on the monitor, the STs are coming down. We've got good flow. We've opened up the PDA. We've done a run with 80 kRPM on the orbital. Wouldn't crack, although it became a crossable lesion. We dealt with the first problem, but we now had an undulable lesion. So our approach there was to do another run with orbital at 120. Now that we've confirmed that the OCT that the vessel is large enough. And now we're going to see if that was enough by taking an NC balloon down, or if we still need more modification.
I always get fooled by I like your choice of longer NC balloon, because if you have a shorter NC balloon and you're actually within a large diffuse segment of calcium, you get a false sense of expansion. I usually call it. This way you'll realize how far you're in and actually get a good sense of whether the balloon is actually expanding.
We're at 20. It's not rupturing. Interesting. So even though you did with 120, it's still not expanding. I think we're going to go with shockwave here. Let's open up shockwave, please.
That's good.
Yeah. So
I think 3.0 shockwave, you'll get good modification in that specific area where the lesion is not yielding.
Yeah, we'll see how far we can get with this.
The balloon needs to be prepped without air to be able to deliver the energy. But even despite that, you can see the balloon looks more symmetrically expanded than on your first inflation. So you've modified the
Go up again.
plaque to some degree already.
you can see it there.
Yeah.
This is the spot that we had issues last time.
Looks
Okay, we're going to deliver
See?
here.
Yeah, beautiful.
Yeah, that's better.
Yeah, this was very underexpanded last time with the other balloon. Okay. I think we might be in the good with the calcium. I
Yeah,
just hit
hit the whole thing. Use the whole. You paid for it.
Yeah, you paid for it. Let's use all the
All the
There we go.
pulses.
We're going to maximize our. I'm up at 8 again. We're delivering therapy here.
So after this, you want to take another NC balloon, like to take that 30, just make sure it expands well, and then we'll do an OCT run.
I think so.
That's good. So we're checking our AZTs routinely, and this type of case, you'd want it to be more than 250.
Let's hit it again.
So it's
Delivering
279
therapy
currently.
Right in the prox.
Undersurface.
Perfect. I think we're out of the therapy here. Okay.
All right. So let's take this out and take the 3.0 NC balloon in.
That's pretty impressive. Even after multiple runs, at least I think we needed the atherectomy to be able to deliver.
Yeah, this was an uncrossable lesion, right? So that's up to 20 there.
I don't want to rupture it again.
I think it's expanding.
Yeah.
Good.
I mean, that's the best we're going to get. Good.
Off there to make sure it's. It's going to.
I'll hit that part too. Yeah.
Hmm. Oh yeah, that looks
Yeah,
pretty
I think it looks
cool.
very
Looks
nice.
great.
Yeah. Good. All right. Let's take this out. Do an OCT run. What we're doing here, we have the balloon sticking halfway in, halfway out, as you can see there.
I'm holding
And then
up the
we're-
guideliner and the balloon.
Push the guide liner and the balloon as one system. It's kind of like the balloon. That's not working.
Okay, let's do the.
Okay. So then I'm coming down with the balloon and see if you can get it down a bit more. All the way to the PDA. Oh, that's not going either.
I think what's happening is
So if this doesn't go, then I would take a fine cross down in exchange for a wiggle wire.
yeah, I think that's
Because your problem is not expansion. Your problem here is you got fractures and rough edges and tears that are getting caught up with this gear.
Your other option would be put a buddy wire down into the PDA, put a balloon in the PDA, inflate it, put the stent on the other wire, and anchor in the lesion.
Using a distal anchor to cross this segment. Yeah.
what we can do is put another wire, trap the other wire, and then try to drive this through With a 7 French, we could do that.
You'd have to ditch the
I got it.
guideliner for that.
Yeah, I'd have to ditch the guideliner for sure.
Yeah.
Yeah.
Yeah, that's right. You'd have to get rid of the guideliner, which, you know, if you can't deep sea the guideliner, then that's a good option too.
Interesting, eh?
What if you went up there and just tried to?
Let me just see if I can get the guideliner in.
So now we're back to dealing with an uncrossable lesion. Can we take a trapper balloon, please? Just a lot of leaking from this.
Unused 2.5. Without
Yeah.
flight 2.5.
Because because of the importance of this wire position, we've gone through a lot of ablation, cracking, and calcium and dissections.
Have a wiggle wire too.
I want to make
Yeah.
sure that we're doing our exchange as safe as possible. White gauze, please.
Yeah.
This is an over-the-wire system, microcatheter, so we're going to use a trapping system. Other methods would be just to push in, hope it doesn't move. With a lot of calcium there and lock it might not. You could use hydraulic exchange or use extension wires. I don't find hydraulic exchange works well with the turnpike system, though. We'll need a trap first. Let's load this one.
Yeah.
You need to go up because I touched the corner of it. I'm thinking if you get the
So I'm
microcatheter
pushing
with
this
another wire down.
trapping wire in and the guide next to the wire. We'll go to the second marker and then we'll just inflate it there. Go up there.
Oh.
Then our next step would be to open this anyway. So might as well try and get it done with the one microcatheter. So I'll just take this down as much as possible. So
Yeah,
I
I
have
keep
to.
going because once this is in,
Good. So a wiggle wire is a support wire that's got a few bends on it. The idea is that these bends will keep the wire and the system anchored more distally, and it'll keep the delivery part of the wire more centered away from the wall. So yeah, I mean, our problem was not expansion. Our problem was not
Interaction.
tight lesion. It's interaction. So the wiggle wire managed to keep everything more central and anchored it distally, where the, not even the balloon or stent, the guide extension flew down there up until the distal lesion there. So I'm hopeful this should be enough to deliver the stent.
now that you have the guideliner in, I think we should not lose territory gained.
Yeah,
I would go with a 3.5 long.
I don't know. We don't need to go high pressure there.
No, that's good.
It's just we did for the distal RC. We just want to make sure the stents are opposed and well expanded down, and it's in a relatively healthy segment, so it's not like it's at any risk there. Okay.
20, yeah. What do you think of the mid 375 for that whole mid
Yeah.
segment?
Yeah, so we'll do the 3.5 pot for the distal stent. We'll do the 3.75 NC for the main stent through its length, or at least the mid stent, and then we'll do an OCT run, and and then hopefully we're done. This
I
is
can maybe show the hemodynamics. I think our patient's comfortable as these are resolved.
Yeah, those ST elevations that we had earlier are gone. We've turned down the pace wire. He's not pacer dependent. Let's
Yeah,
just
we
do a
just-
cine now in case, just to show that for the live
Hold
feed
on
part.
to the guideliner is going to pop out of there. That's very nice.
So that's our PCI results.
Looks good.
I think very well expanded, at least in this angle. The edge of your guide liner or guide extension is square, and it's getting ratcheted against stents. So by having the balloon sticking out, it smoothed that transition and allowed us to deliver it with quite a bit of ease.
You can see the
Yeah.
expansion is excellent.
Yeah.
Yeah, I mean, on your longitudinal angle there, you can
And
see
then
it's
the
all
areas, as
white.
you mentioned, that aren't expanded. This is probably a bit underexpanded.
Swirl.
Yeah, it's
Yeah,
a
that's
swirl,
swirl
but
in
there's
there.
probably still some underexpansion compared to the other area. But yeah, very nice result.
We crossed with the orbital. We got ablation. We know we got ablation done because we were able to cross with equipment. We got the OCT across our balloons, but it still was a non-expandable lesion. We tried ablating further with the 120 kpm mode, but still would not expand. Shockwave did the win there, got us expanded. We had challenges with delivering equipment afterwards, where we had to probably from interaction, where we had to switch to a wiggle wire using a turnpike spiral.
Mhm.
And a guideliner helped there as well. And based on our OCT images, we've got very good expansion.
Again, thank you so much, and we'll see you next time.